All right, so they'll get that figured out. And then for those of us that are joining us online in the virtual world, they can miss out on the beginning. All right, so welcome. Last time I did this spinal workshop, I went way over. So if you guys joined me at that one, I'm really sorry. This time we're really gonna try to keep this one on time, but if you need to leave after this half hour is over, please do so. You are not going to offend me or anybody else whatsoever. We really try to honor your time here. All right, so this is creating the perfect adjustment. So my vision for this spinal workshop is really to take you through the method which we use to diagnose subluxation, figure out exactly how the spine needs to move, and then translate what we see on the x-ray to an adjustment. And then I'm going to walk you through an entire adjustment, full spine, using the spine as a model as well, talking about exactly what the different adjustment techniques do in terms of moving bones in certain directions. Super pumped about it. This is my favorite part about being a chiropractor. Not necessarily marking x-rays. When you do a gajillion of them every single day, it gets a little tedious. But what I love is adjusting the spine. It legitimately brings me so much joy to move bones the way they need to be. Both of my sisters are amazing artists. My father is an artist as well. I'm an artist too, but I didn't get any of the three-dimensional sculpting skills that they did or the drawing skills. I kind of feel like I'm a physical artist. All throughout my life, I did martial arts, wrestling, grappling. I love using my body. I love the leverage and the torque that you can get with different body positions, and I love being able to deliver really good adjustments. It's one of the things that I pride myself most on in being a chiropractor, is delivering the most right adjustment at the most right time, being extremely specific. Solving clinical problems with adjustments brings me a ton of joy, so I love being able to share that with you guys. All right, so let's get started. This is Rachel's spine. She has generously volunteered her spine to be the model for today. So all of the markings that I had on this previously I've erased. I'm going to take you guys through the method. So the first thing that we're going to do is I'm going to, I don't have a side here. I'm going to line this guy up, and we got to make sure that this is level. And once it is perfectly level, then I can use this straight edge. The first thing I want to do is a cervical plumb line, and that really helps the patient, you guys, see lateral curvatures in the spine where they're not supposed to be. So we'll start from the side here. We will line that up, and then with that we can go forward, find the middle of the dens, and if somebody would grab me that model, I'd really appreciate it. And then we'll draw that plumb line down. Perfect. So when I say the dens, that's a part of C2. C1 is the topmost bone. C2 is the second topmost bone, and you can see that there is a bony projection in the middle there. It's kind of underneath that guy. And that's the middle of that we'll use to determine that plumb line. And you can see that bony projection right there. So there's that plumb line. Another thing that we'll then do is I then label all of the vertebrae. That's C1. C1 is that ring of bone right up there. C2, C3, C4, C5, C6, C7, T1, T2, T3, T4. We can see the top of T5. I'm not going to measure that, or I'm not going to label that. So there are 7 cervical vertebrae. This helps with a couple of different things. Number one, we can see if there are any cervical ribs, which there should not be. We can see the shape and the length of the transverse processes. Those are the bony projections out the side right here, because C7 can sometimes have an elongated transverse process, which can have a negative effect on blood flow through that area and also nerve flow through that area. So all really important things to see. And then later during a report, I don't have to constantly count up and down to talk about which vertebrae we're talking about. So labeling them is super helpful. Beyond there, I'm then going to label and mark the tip of the spinous process. That's these guys right here. And then I'll just go through and mark each of those. So C2 is right there, 3, 4, and so on and so forth. And I just mark the very tip of those. Now that is really indicative of spinal alignment right there. So if we mark a spinous process and it's way over to the right, what you're looking at there is literally a subluxation. So if I take this, and we've got C2 right there, and I rotate C2, look what happens to the spinous. I'm going to rotate C2, and the spinous will go off to the right. You see that? And so we know that Rachel is lined up straight to the X-ray, and we know that that plumb line is level and plumb, and so we can see that rotation right through there. Now I start to utilize the plumb line and my understanding of anatomy, physiology, and the skeletal system to then start deciding clinically how I'm going to move what where. So we're going to move C2 and C3. What I'm marking here is the body malposition. So we've talked about the spinous. Now let's talk about the vertebral body. That's in the front. So if the spinous is kicked off to the left, the body is rotated to the right. All right, cool. Sorry, I just gave you guys a lot of different weird things that were all incorrect. Left and right is not my forte. So I wanted to write left here. So the body is to the left. So let me start that over. Sorry, everybody. Okay, so the spinous is off to the right. All right, we're getting everything correct now. The spinous is off to the right. That means the body is misaligned to the left. Now, conveniently, I'm marking that body malposition, but it also tells me, looking from the back, which direction I need to move the spinous. So if the body is misaligned to the left, I need to move the spinous left to get it back where it needs to be. So it's very convenient as I'm looking at the x-rays before I perform the adjustment, I know that I got to move the body left, and it's marked conveniently right there. So that's how we're going to move Rachel's upper cervical spine. We're then going to move down into the upper thoracic spine. So it looks like T1 is lined up perfectly right there, because you can see that that spinous is lined up right with that plumb line. Okay? But the other thing is you got to see where that spinous lines up with the rest of the vertebrae. And if we line up the rest of the vertebrae, it is off to the right. Excuse me. It's off to the right. So I want to push that left, so we know we have a T1 left body malposition. I need to move that spinous that way as well. And then below that, it's got to go the opposite direction. So we'll get T3 moving the opposite direction. So very commonly, you will see counter rotations with those vertebrae. So one spinous will go one way, the other will go the other way. Puts a lot of torque on the disc, puts a lot of torque on the nervous system. We need to undo that, and we can do that right through there. On top of that, we can see some lateral curvatures here. So if you're looking at Rachel's upper thoracic spine, you'll see that there is a lateral curvature in that direction. I'll give myself a caret so that I know that if I'm inducing lateral flexion that way, I'm pushing that spine the way it needs to go. So that's Rachel's anterior or posterior view. And then we can talk about the side view right here. So looking at this side view, we'll start off, we can label all of the, did I lose my pencil? Yeah, okay, so we can start off by labeling all of the vertebrae here. We've got C1, again, 2, 3, all the way down to C7 and then T1, and then we want to get our forward head carriage measurement. So with that will come, we get our plumb line ready. We're looking at the anterior part of C1. That should line up directly with the back of the anterior arch of C1. So we got C7 down here. That should line up perfectly. I'll drop that down right here. And then we can see there's just a paltry 2 millimeters of forward head carriage. 5 millimeters either forward or rearward is really the gold standard, and that's what you want to achieve. So we'll measure the top of that to the front of that, and long story short, when then we translate that to the model, that means that the front of this guy, C1 right here, needs to basically line up to the front of this guy down here, C7. And that'll indicate really good alignment from the side view. And that's a good objective way to measure the health of the spine. And then I'll mark those. If there is an individual in like continued wellness or maintenance care, we can then work on inducing a good curvature. So you might see a caret like that. That's telling me to put pressure right here through C5. And if Rachel has a cervical orthosis, she's going to be working on the apex of that orthosis at C5. So basically, a cervical orthosis, can I grab one? Is a specially shaped foam block that you would lay on. And the reason why that works is because it has an apex on it right here. And long story short, this lays on the ground just like that, and it puts pressure into the curvature. And using this over time helps get that curvature back. We've seen really good results with that too. But this side view of the x-ray is really going to show us exactly where the peak of that curve needs to be when you're doing that rehabilitative work. So that's how we'll look at the side view. The side view really shows us the health of the spine, if you'll remember. So in this view, we're really going to pay attention to disc space. We're going to pay attention to the shape and the quality of the bone to make sure that the spine is really as healthy as it should be. And where it's not, we know that we can focus. So for example, if Rachel had phase 2 degeneration in the lower cervical spine, then that would direct my attention to focusing adjustments on the lower cervical spine. Does that make sense? So if we've got phase 2 degeneration down there, those are the spots that really need to start moving again so they can be healthy. Joints that move are joints that can be healthy. Remember, part of that definition of a subluxation is joints that are not moving the right way. And any joint that loses a degree of normal range of motion begins to deteriorate or degenerate immediately. So if we see degeneration, we know that there's been abnormal motion in that location for many, many years. And that's where you want to direct any kind of adjustment efforts. The other place to really pay attention is in the upper cervical spine. And we're going to look at the relationship between C1 and C2. So when we're looking at C1 right here, there are these two triangular, and I'll kind of trace them, pieces of C1. And what that translates to is you're looking at these blocky parts of the bone right here. C1 needs to be, number one, centered around C2 so it's not translated at all. It needs to be dead center. It also needs to be level. And oftentimes you can see a tilt through there. And if I erase those markings I just drew, you will be able to see, perhaps, what I'm talking about here. So we'll make sure that this is level again. All right, and when I draw the bottom, I'll trace the bottom part right there and the bottom part right there. You will see that the right side is lower than the left. Rachel's atlas is tilted, so we know that this needs to be moved up in that direction. And we can absolutely achieve that tilt as well. The next thing we're going to look at is to make sure it's centered. And so for that, we will look at the one corner and the opposite corner, and then where C2 is. And when we're looking at that, do you see the gap here versus the gap there? The gap is much smaller on that side. That means we know that C1 is translated that direction. So we'll move the atlas, translating it to the left to recenter it. And the atlas is very sensitive. So making sure you get that right is huge. So, analyzing the x-rays this way is not the be-all and end-all of how somebody needs to be adjusted. There's a lot of other indications too. So, regional inflammation, tenderness to palpation, my own palpation of what I feel and how that thing is moving is all pieces of the puzzle. You can imagine that if we're looking for a needle in a haystack, this is going to show me where in the haystack to look. So if we've got this big mound, I can look here, okay, that's the needle. Make sense? And that's how we use the x-rays. And ultimately, your subluxation patterns will not change over a long period of time. Okay? It's like your hair naturally parts one way. To change that part in your hair, it's going to take a lot of repetition. Make sense? So most of us, the reason why we do annual x-rays is because our subluxation patterns do not change a ton given a lot of time. So you'll notice that we get into a rhythm of similar adjustments over many, many adjustments. And they don't change until we get a new set of x-rays and see what needs to change and where. Okay, so let's look at Rachel's lumbopelvic spine. So we've looked at her neck. Let's look at her lumbopelvic spine. Rachel, go ahead and change your atlas listing, please. All right, let's start with this one from the side here, and then we'll move into this one from the back. Again, from the side here, we're going to label. I know that Rachel only has 5 lumbar vertebrae. Some people have 6. In the general population, it's very uncommon, but in our practice population, it tends to be a little bit more common. You can imagine that if you've got 6 lumbar vertebrae, there's more likelihood of having a low back problem. You've got an extra joint there that most people don't have. So in our practice population, it's more like 20% have that 6th lumbar vertebrae. So we look for it a little bit more regularly. So we'll label that So here we're looking at the curvature of the spine. You'll notice that Rachel's upper lumbar spine is more flat than the bottom part. And so in this portion of Rachel's care, it's absolutely appropriate. I can draw some carrots to induce some extension through the upper part of her low back, utilizing the arthrostim to help normalize that curve and make it more of a constant radius curve from the top to the bottom. That's going to help out with the discs, because then if there's a constant radius, then all of the discs have a more consistent load on them. Whereas if the top is flat and the bottom's curved, it's going to put undue pressure and strain toward the very bottom of that spine. And you'll notice here, if we're looking at these disc spaces, okay, there's some lateral curvature here, so that doesn't look like it's as thick as it actually is. But if you look at this disc space versus this one, that's actually thinner than that. And this bottom one should be the thickest. So we can see that Rachel's got some lumbar disc degeneration at the lowest part of her low back. No bone spurs, and ultimately that's really the only spot that's degenerated at this point. Very classic early phase 2 degeneration. Okay, so now that we've looked at her spine from the side, we know that we're going to have to focus on 2 places. Number 1, this flat spot at the upper part, but number 2, and more importantly, that degeneration at the lower spot. So we need to do a couple of things here. Number 1, let's get this level and plumb. All right, so one of the things that we got to do is we got to figure out where her pelvis is at. And if we could see the tops of her femurs, we could measure any kind of leg length discrepancy here. Now, one view and one shot does not determine leg length discrepancy all by itself. Because if Rachel was twisted like this, you could understand that because an x-ray is almost like looking at a shadow, that could be distorted. But if we have multiple x-rays over time and we see similarities x-ray to x-ray, we can know pretty definitively whether or not there's a leg length discrepancy. Now, I will take a leg length discrepancy at virtually face value when I first see one, just because I know the competency of our x-ray team, and usually it's not a mistake. It's not usually a projection issue. It usually is a leg length, especially when we see that in conjunction with a pelvic discrepancy as well. But we'll measure that like this. So we'll make sure we've got our plumb line here. We'll level it out, and we'll go to the top of one pelvis to the top of the other one. Draw that across. We've got 8 millimeters of pelvic tilt right through there. So we need to address that. So what does that even mean? I'm not suggesting that Rachel's pelvis is tilted like this, although that could be part of it, especially if there's a leg length discrepancy. But what we're really looking at is the rotation of the pelvis. So you will notice that the pelvis looks like an oval, basically. And if I take an oval and I start to rotate it backwards, do you see how the top gets higher? It's like standing up a tree. The top gets higher. So what we're seeing here is in Rachel's pelvis, the right side is rotated like that. Stay up there, guy. So the right side is rotated like that. And so what we need to do is then address this by rotating it back forward. And by doing that, we can adjust this SI joint, level the pelvis, and give her spine a level foundation to work from. And over time, the pelvis can be trained not to subluxate quite as often. The other thing we can look at here is the sacrum. And oftentimes you can actually see a sacral subluxation. If you look, the sacrum will tend to subluxate this way or that way. And if you can imagine turning this into a two-dimensional shape, you will see this ridge start to drift one side or the other. Rachel's is pretty level right there, so I would have to address this with some leg length checks and some sacral checks. But after, let's say, 3 sacral checks in a row and it's constantly left-sided, we'll just draw a caret and then I'll know, let's check the left side. And if it's not there, we'll just leave it. Sometimes you can get into a situation where chiropractor adjusts right pelvis, and then next time person comes in and it's the opposite, and then the chiropractor adjusts the other side. And they come back in with another neurological check, adjust the opposite side. I find it's a lot more clinically relevant in my practice, and I get much better results if I am knowing that Rachel needs this right pelvis rotated anterior, and she comes in one day and it's actually the opposite, I'll just leave it. So her body's starting to use that other direction, but cool, it needs to go that way for a little while. Now, if it's like 3 times in a row and it's still the wrong way, we can adjust it in that other direction, but for the most part, I'll leave it where it is. Interestingly, sometimes during the course of a spinal correction, somebody will fall into a flare-up, and it's where you're experiencing very similar symptoms to the ones that you brought to the practice in the first place. And weirdly enough, the only thing that will get somebody out of a flare-up is putting them back into the position that they brought here in the first place. So for example, we're adjusting Rachel's pelvis, moving it the right way, turning the spine every single which way it needs to go for that correction, then all of a sudden she just can't make forward progress, she's in agonizing pain, and the only thing that helps get her out of symptoms for a short period of time is we put it all back the way it was when she got here. So we put this pelvis back, we turn all this stuff back the opposite direction that it really needs to go, and then all of a sudden her body can chill out a little bit. And then once she's out of the flare-up, we can start with the correction again. But have you ever had your hair in a really tight ponytail? When you take it out of the ponytail, your hair hurts, like your scalp hurts. You have no idea what I'm talking about.
Oh, he was a mullet boy.
Oh, yes, I do.
Wonderful. All right, so everybody knows what I'm talking about. I love it. But long story short, we are creatures of habit. Our body is elastic. We've got muscle memory. And your body knows what it's doing. It's responding this way, and these postural distortions and subluxations a lot of times are happening for a reason. And once we start pushing things back to the way they're supposed to be, there can sometimes be a little bit of symptomatology when we start rocking the boat back in the direction it needs to go. You can imagine that if your arm was bound up in this position for 10 years, it is not normal for it to be like this. But my body would make some anatomical changes and physiological changes to adapt to that. And if we were to start a rehab program where we start systematically opening my arm back up, there could be some pain there. Make sense? So sometimes that interesting phenomenon can happen as well. So let's analyze the rest of Rachel's low back. Again, we're going to mark the tips of the spinous process, and I will remind you guys exactly what part that is. So we're looking at the low back right now, and the spinous process is this spiky guy in the back. We mark that guy. We also need to get another plumb line. So we'll line this puppy up. We will slide it over. We start with the base of the spine, and we're looking at utilizing this little notch right there. That's S1, the sacrum, and we'll draw a plumb line from there. And that allows us to see the shape of the spine. You'll notice that Rachel's got a lot of curvatures going around here. So if Rachel's pelvis is tilted like this, okay, and her foundation is tilted, you can imagine that if her eyeballs need to be level with the horizon for her to walk around a normal functioning human being and not walk around like this, these curvatures need to be there. They absolutely do. And her body is adapting. And if she has a leg length discrepancy, those curvatures are going to be there forever. Because they have to be. Because if you literally have a foundation that's tilted, the structure needs to tilt and move with that. We're not static buildings. We're living beings that adapt to the circumstances we're put in. That's why the 49ers would walk around and they were literally hunched over like this because they were digging in mines for decades. And their bodies adapt to that. Your body will adapt to anything you ask it to do. So watch out what you're asking it to do on a regular basis. Now, sometimes over the course of initial care, we'll take another set of x-rays after a year, and guess what? These lateral curvatures on this view, they get more extreme. Why is that? Well, adjustments help your body adapt. So if your brain has a better understanding of what's going on within your body, and your nervous system is more connected, you're going to adapt better. And so ultimately, sometimes those curvatures get worse by a few degrees after a year of initial care. Rachel's got worse, and she was really upset. But then I had to remind her that Casey's was the exact same way. Casey's more experienced in her chiropractic care than Rachel is. And I showed her 13 other examples of somebody through initial care whose curvatures got worse, quote unquote. I'll use that because it's not worse. Her body was functioning better in every single way and adapting better in every single way. She was healthier, but those curvatures were more extreme. And then we took these again, and they were better than they started at. And so ultimately, 2-3 years into this process, we see the spine start to straighten out because there's just a better way to adapt than it chooses to at first. But these will probably never be straight because of this pelvis issue, which is probably a leg length thing. And we wouldn't want them to be because then she'd be walking around like this. All right, so looking at this, we can see how things need to move. These guys up here need to rotate this way and get pushed in that way, so we're going to do a caret, and then L1 needs to move right. We're looking at a right body malposition, just like we did with the neck. But in the low back, it's kind of easier to see because these guys are bigger. If I push this guy over to the left, then the body is moving to the right. Make sense? And this whole thing is curved this way, so we need to push it the opposite direction. I'm not expecting it to move that way and stay there permanently. But if she's walking around like this all the time, it's going to be healthy for her joints to move in that direction as well. Because joints that are stuck deteriorate. We need to unstick the joints so they can move and heal and be healthy. Make sense? Okay. And last thing is we'll address L4 down here, and that's got to go left. And then we'll also induce some lateral pressure into there. It doesn't look like a ton right here, but from her past x-rays, we know that needs to happen. So a lot of times if I see that we're making really great changes posturally with a certain set of listings, we'll probably keep that for a while, even if it looks like it doesn't. And it's not saying that I'm going to adjust it that way every single time, but I need to look for it. A great example is a patient that's been with me since Rosemont. She's been a wellness patient for like 4 years now, okay? And her atlas has a certain listing. It chooses to subluxate when it does, translated to the right. So on x-ray, it doesn't look like it needs to be adjusted anymore, but I still check it, and when it's subluxated in that direction, I still adjust it. Because when it does subluxate, it goes that direction, and if I don't, she'll have a sinus infection. So it's really important for us to check that. All right, so that's how we'll analyze the x-ray. I want to show you guys how this translates to an adjustment. So if you guys would be so kind as to just rotate your chairs a little bit. I need some room to work and move here, so if you'd like to stand up, you're welcome to. I'm also going to show you on the spine exactly what we're going to do here. All right, Rachel, go ahead and lie down. All right, this is really cool. So Rachel's adjustment in the mid-back of choice lately has been an anterior thoracic adjustment, so we're not going to start with her mid-back like we do with most of you guys. We're going to kind of do that a little bit later in the whole process here, but we will address her cervical thoracic junction. CT junction, where the cervical spine meets the thoracic spine, you'll remember, needs to rotate like this. So if we take the spine here, what we're looking at is her spine just like that. Pretty cool, right? She's the perfect height. And what's going on up here is that these guys are twisted this way and also rotated that way. Can you guys all see that? So what I'm going to do is I'm going to use this contact of my hand. There's a bone in here called the pisiform. It's probably there because chiropractic is that important for the species. It literally looks like a hook. And with that, I can grab the bony protuberances of your guys' bones. Pretty cool. And I kind of grab it with this muscle right here. It's really cool. So the pisiform is important. What I'm going to do is I'm going to come in on the transverse process, and I'm going to push the transverse process this way to induce this kind of motion with this joint. All right? And that's going to be right up through here. So this guy, would you be so kind? Thank you much. So we're going to find T1, which is right below C7. C7 is the sticky outiest one. It's also called vertebra prominens, which in Latin means the sticky outiest one. And we're going to come right through here. Pisiform goes right on the transverse process of that bone right there. Perfect. And so that rotates the whole thing that way with lateral force that way. All right, let's address the pelvis, if you would, please. Thanks, Becca. All right, so we see the pelvis right through here. Remember, her right pelvis is rotated backwards like this. We'll show that again. It's rotated backwards like this. So we're going to use this bone right here and push this like that using the table. So the table is going to pop up. I'm going to find this part of the bone, and again, with that pisiform, I'm going to push this way. But now we're also going to check the sacrum, okay? And we're going to check the sacrum using her legs. And this is a technique that's borrowed from Larry Webster and Webster technique. We use it on athletes and pregnant women. And ultimately, thanks, Marnie. The leg that has more resistance is the side that the sacrum needs to be adjusted. And Rachel's have both equal resistance. That means the sacrum doesn't have a laterality to it. I will contact the sacrum just to give myself a little bit more torque for this. So I can push here, but then the whole thing's going to move. If I block here and then push, do you see how we're going to get really good twisting right in that SI joint? So that's what I'm going to do. Thank you, Marnie. And we'll use the table. So the table's going to pop up. I'm going to find that spot. It's called the PSIS. Right there. And then I'm going to block the apex of the sacrum. As I push, when the table drops, that sudden stop is what causes the sacrum to move. And so part of this is part of Thompson technique. I use a variety of different techniques in the Marco Accordo adjusting technique. We call that, it's true. We call it diversified, because chiropractors find different techniques and the magic that works for them in each of those techniques to create that doctor's personal technique. So we'll use some Thompson, we use some Webster. And what's cool is that her leg lengths are very level now that we've adjusted her pelvis. I wish I could have showed you guys before, and I didn't think about it, but next time. So 6 months from now, when we do this again, I'll show you that leg length discrepancy, and you'll literally be able to see that leg length change as the pelvis is rotated. Okay, so now we're going to address her low back. Laying your side, face me. And the model, please. So what we're going to do here is Again, with that piezoform and also with my leg, I'm going to get my piezoform on the mammillary process of the low back, grabbing that, turning, and then rotating it like this. Do you see how it's rotating and twisting just like that? And for you guys right over here, I'm going to be rotating and twisting it just like that. So my piezoform on the mammillary process. Chiropractic adjustments are all named for my contact, the position of the patient. So this one would be a side-lying piezoform, mammillary process, push. Very uncreative. The names that you guys come up with are way better. Got one patient that calls it ragdoll position. That's one of my faves. All right, so we'll find that PSIS that lines up with L5. We need to be at L4, which is one up from that. And then from here, piezoform and grade adjustment right through there. Love it. All right, other side, please. Okay, same one, but this is going to be a little bit different here. We need to get a lot higher. To get higher in the spine, we need to induce more flexion. So if I'm pushing right here, I can be low in the spine and I can be here, but if I need to get up here, we're going to flex the spine to get these joints to gap. So notice as I flex, these joints gap, and then I can get more pressure right through there. For this one, just for the sake of diversity, I'm going to do a pull. So with this one, I'm going to use my fingers, grab the spinous process, and pull them that way. Make sense? So rather than pushing to get the same direction, I'm going to do a pull. Just like that. All right? Cool. Thanks, Becca. All right. So from here, we got 5, 4, 3, 2. We'll go one higher. We'll do a 1 right there. Now I'm going to flex until we feel the gap in that joint, and then I'm going to use my fingers and pull. Perfect. All right. Go ahead and lay on your back. Right on. So now we're going to adjust the neck. So to adjust the neck, we don't use the transverse process because there are none in the neck. We use the articular pillar, and that's this guy right here. And long story short, we are going to laterally flex the spine. Okay, we'll do it the direction it's going to be. We're going to laterally flex the spine, just like that. And then I'm going to use my fingers to rotate right where it needs to rotate. This can be done with a direct push if you want to. Which if you have enough lateral flexion and then rotation, you can see how I can induce more by just pushing that way, and it's going to rotate like that. That's kind of the way they teach you first because it's very safe to do it that way. But as you get better feel and you've adjusted more patience, you kind of do a combination of like a push and also a lift to get that rotation right through there. So just to give you an idea, this is going to be just like that. We'll find C2 and C3. So I line up right on C2 and C3 with my finger, laterally flex, turn, and then lift just like that. Make sense? Cool. All right. Let's do it. All right, Rachel. All right. So we know that C2 is the first part of the articular pillar that you can feel. C1 is much higher, right under this mastoid process, the hard thing behind your ear. So that's going to be where the atlas is. We go one below that, we know we're at C2, and then one below that's C3. Both of those need to move, so I'll kind of address them both. So we're going to go laterally flex, and then we rotate, and then from here, adjust just like that. All right, so I can, but it would not be as comfortable. We can also do that with the thumb. So I won't adjust this time, but we can set it up. I can come way over like this and then use the thumb to then adjust it like that. And sometimes if there's a particularly stubborn segment, we'll do that. It induces a lot of rotation, so it's not the go-to, at least for me. We can also do that prone, so go ahead and flip over, please. And to do that prone, what we would do is laterally flex, rotate, and then I could push right here like that to then, from this side, push the articular pillar like that. And for some people, prone adjustments are just the bee's knees. They love them. For other people, not quite so much. Okay, on your back, please. Okay. So Rachel's atlas is a little squirrely.
Nicest thing you've ever said.
It's a little squirrely. So I don't ever just adjust off the listing for Rachel. A lot of times there's neurological checks that we can do, but I'll ask her how her head's doing. So how is your head?
It's great.
It's great.
Yeah.
Okay. So I'm not going to adjust Rachel's atlas today. But to adjust the atlas, we've got a couple of different ways that we can do that. Go ahead and lay on your side with that side down. Okay, the first way we can do it is using the scalenes and they are muscles. So if Rachel's laying down just like this, the scalenes go from the upper cervical spine, like C1, down to above the collarbone. And if I want to move the atlas that way, I can literally take the scalenes like a guy wire and push on the scalenes until it then translates the atlas that way. Really cool. The other thing I can do is use the table, and we pop the table up, and I literally will just come from behind using that piezoform again and push until the table breaks the drop, and then that quick sudden touch will then move the atlas sideways, and then I can recoil on that, and I'll show you guys on the spine. So go ahead and move, Rachel. So we got the spine right here. All right, stay there. And so what will end up happening is we'll bring that guy up just like that. From the back, we put the piezoform onto the atlas right there. And then from here, we'll deliver an impulse and push right through there. And so that's how that works. So I was forceful on that because I wanted the drop to activate so you guys could see what can happen. But we really just used just enough pressure to activate the drop, and then that sudden stop will then move the atlas. Raise your hand if you've had an atlas adjustment. Yeah, awesome, cool. Huge differences in just the way your brain works when it has enough oxygen. The reason why the atlas is so important is because your brain stem sits right in there, and all those nerves that wrap around the atlas and right up here control the blood flow to your brain. Your brain needs enough blood flow to work the right way, guys, and if it doesn't, weird things can happen. So, all right. That's a full spine adjustment. There's other adjustments that can happen. Oh, the mid-back. All right. Yes, Rachel's favorite. Okay, so with Rachel's mid-back, what we're going to do is we're going to turn this whole thing upside down. And long story short, I'm going to use my fist. You'll notice I've created a valley with my fist right here. In that valley, the spinous process will go, and then my thenar eminence, which is the thumb pad, and my fingers will create a nice fulcrum for the transverse processes on both sides. And from here, I can extend the mid-back and get great adjustments through there. All right, nice deep breath in, let it out. Awesome. Too easy. Okay, cool. Come on up.
Thank you.
All right, gang. My hope is that with this spinal workshop, you could get a greater insight as to what goes into an adjustment. A lot of times if you're sitting in the hot seats, it could look like everybody's getting the exact same adjustment. And that I do the exact same thing with every single person, for 100 patients a day, 300 different adjustments a day, everybody gets the exact same thing. But ultimately, I can do 5 different side posture adjustments. The technique varies so little, you just don't understand it because you're not trained in how to adjust. And we're also doing different segments for everybody as well. So if I'm adjusting L1 for Mrs. Jones, and Mr. Jones gets an L2 in the same direction, it looks like the exact same adjustment. But we use similar techniques because we get good at them, and they work really, really well. Rest assured, everybody's getting unique adjustments for them. And also rest assured, if there's a technique that isn't working for you, we've got a gajillion other ones to adjust the exact same bone in the exact same direction, and we will absolutely find one that works for you. We didn't even talk about the arthrostim, or the activator, or all the other myriad of techniques we have available here at the office. So please share what you learned today.